Okay.
Hi, everybody. Welcome. So glad you could join us for our monthly Echo Geriatric Clinic. We have great topic and a great speaker today. So let's get started. Next slide. Okay. Free CME, distance technology, online learning, and of course, an opportunity for case discussion. Hope that this talk, jogs a lot of your, brings up some cases that you want to discuss and share your challenges, and we'll all put our heads together as a team and learn together. Next slide. Okay, so the key to really the benefit of the Echo is sharing your cases. And we love challenging cases, and that's why we're here. Just make sure it's HIPAA compliant. Next slide. So confidential, safe, HIPAA compliant, no personal information, and we want to foster a culture of mutual learning and encouragement. These case consultations do not create or establish provider-patient relationships between any of the specialists or the panel, and with the patients or cases that are being presented. Next slide. And in order to receive CMEs, you've already registered, but then afterwards there will be a link with the evaluation. So just complete it right after this session. Next slide. Just wanted to let you know that we're doing a little transition over here. The Hawaii Consortium for CME will no longer be providing CMEs for us after December of 2022. So for any CMEs that you want from previous sessions, you will need to go online to access them yourself. And you can find the instructions in the resource tab of our Echo website. And these transcripts will be available. They're gracious enough to keep them up for several more months, for another 9 months or so, until September 6th. There's a link in the Echo website to tell you how to get access to your own CMEs. And then going forwards, after January, we will be obtaining CMEs for physicians and nurses through the Queen's healthcare system. And other disciplines will be able to receive attendance credit. Next slide. Okay, just a reminder on Zoom logistics, as I'm sure you know about. Make sure there's a chat tool, and if you put your name and others joining the session with you today, that's a great way of our keeping attendance. And of course, make sure you're muted if you're not speaking. Next slide. Just a little bit introductions. We have a hub team here. We have a special speaker, but we have an interdisciplinary team to just answer questions as needed. So myself, I'm Dr. Wen. I'm the course director for the Echo Geriatrics Clinic. Sarah Tompkinson is a social worker, but she's the special speaker today. She has 41 years of experience in geriatrics, health, mental health, and long-term care. She's worked many years at the VA, and she served at Holly Kawiki's Memory Care Center. She's been a social worker at Central Union Adult Daycare Program, and she's now working as a case manager at Straub. We have Mary Gotham here as well. She's a retired public health nurse from the Department of Health. And I'm not sure if Lucas is here. Oh, there he is. Yay, Lucas. He is with Keolani Counseling and Mindfulness Services, and he focuses on mental health for older adults and families. And I know Chad cannot be with us today. But anyway, yes, let us welcome Sarah Tompkinson. And let's pull up the slides and get started. Thank you so much, Sarah, for joining us.
Of course. This subject, as you know, is very dear to my heart because for a number of reasons, I was a family caregiver for my in-laws. My mother-in-law, who I helped my husband care for, lived to a great age of 103. And she just actually she woke up one morning, we found her and she had passed away. But those experiences of working with them, living with vascular dementia, and my own parents, one who's dealing with mild cognitive impairment, and my mother with a recent diagnosis of Parkinson's disease. So, being a family care partner gives me a very different perspective than that of a healthcare provider, social worker. And this topic is probably of interest, I hope, to everyone. And what I want to challenge you to think about before we begin is, can you just imagine yourself rethinking or reframing how you will look at people that you're caring for that have, it's not just dementia, but it's people that have cognitive impairment. And if you can begin to look at yourself first and how you respond versus react to the person, it makes a difference in the quality of their life. So, can we get started? Ooh.
Oh, no. Okay. Who's sharing the screen?
It's for me.
Oh, okay. Michaela,
I'll-
Michaela, do you have the slides?
I sent you the slides on an email about 5-7 minutes ago.
Okay. Yeah, unfortunately, these slides are having a little Zoom glitch where it's having these big gray out black boxes. And so we're trying to find a version that doesn't do that.
So while you're doing that, I'm just going to go over at least what the learning objectives are. So today, the 3 objectives are, I'd like you to be able to take away from this in-service the ability to describe what is the philosophy of a positive approach to care for persons living with dementia. And secondly, to be able to list the 6 pieces of the puzzle. It's referred to as a puzzle because we're going to look at things that need to be assessed before we can start addressing how to handle challenging situations or circumstances when we are caring for someone with dementia. And lastly, the objective is to be able to identify 2 approaches to improve one's understanding of challenging circumstances or situations as care partners or for your care partners that you work with. So just a little background. I'm not sure all of you have heard of Teepa Snow. She is an occupational therapist, and she's come up with this model or curriculum. Thank you. Oop, the second slide, which has Teepa's picture. That's okay. I think that's it. So pretty much she wants, there we go. There's a little background about Teepa. The key points are in the last paragraph. That Teepa's hands-on caregiving experience does include providing direct care in the community at different programs and wellness centers. What I really like about her approach is she focuses on what abilities people have left, because we all know what people are losing in terms of their physical abilities, their thinking process. But why focus on that when we should look at promoting what function they still have left? Next slide. So having said that, I just wanted to mention some interesting, is it the positive approach to care? Yeah, there we go. This is basically the philosophy for the positive approach to care. She believes, as I mentioned earlier, that we need to look at rewiring our own perceptions and attitudes and communication strategies, because in doing so, that's going to really have an impact on the kinds of outcomes that you're looking for in your relationship with that family member or the person that you're working with. It includes looking not just at the person, but taking into consideration what's happening in the environment that the person's in. And for us who have the healthy brains, we're the ones that are better able to make the changes, right? As opposed to someone who doesn't have that healthy brain. And then finally, to recognize that the person who's living with dementia, they really are doing the best they can. If they weren't doing the best they can, we need to start in helping family caregivers recognize that the behaviors they're seeing in that situation is not that something purposeful or malicious. And then again, as we're interacting with people that have dementia, we as care partners need to take responsibility to change our approach and behaviors towards a person. Next slide. Oh, next slide. So this came out from the Alzheimer's Association and its data from the current year. They were looking at, in 2021, what has been the impact of dementia and caregiving? And did you realize that 16% of Alzheimer's and dementia deaths have really increased during the COVID-19 pandemic? And I'm sure for many of you out in the audience, you know that that continues to be a challenge, is that we're seeing more deaths at home, in the nursing facilities, because of the pandemic or endemic. More than 6 million Americans are living with Alzheimer's. And in 2021, did you know that Alzheimer's and other dementias cost the nation $355 billion? And by 2050, these costs are going to rise to 1.1 trillion. I think this is an important slide because we need to, again, recognize, demonstrate appreciation, and compensate our unpaid family caregivers. So there's a difference when I talk about care partners and caregivers. I'm talking about the unpaid care partners for people that are living with Alzheimer's or other related dementias. Annually, these care partners are providing an estimated 15.3 billion hours of care, which is valued at $250 billion. And without these care partners, I think our economy would be in worse shape. Next slide. So I'm going to ask the audience to, and you can put this in the chat, what are your experiences of challenging situations with dementia care? What can you give examples of what you've seen as those kinds of challenging situations? I'll start with the first one. So one might be, John, can you hit the enter key? And I think I've got them all. So that might be a challenging situation, hitting or biting. Incontinence. What else? I see some people are answering on the chat too. Oh, okay, and then we have wandering and elopement, problems with sleep. That's people getting up in the middle of the night. Insomnia. Another one could be, John, you can go through them. Driving. Oh boy, I'd love to hear from people what your experiences are or have been when you're working with someone that wants to. Bathing. Thank you, Dr. Price. Yeah. And yes, believing that people are stealing things. Yes, the shadowing. I remember when my father first was going through the early stages of his cognitive impairment, he would just follow my mother everywhere. You know, inappropriate sexual overtures, correct, yes. Keep going, and then John, you can just keep hitting the enter key and we'll show some other challenging situations. Undressing in public, the paranoid hallucinations that Dr. Lucas mentioned. Yeah, not eating or drinking. Screaming. Anybody here have people swearing, saying bad words, repeating themselves, asking the same question? And of course, when can I go home? I need to get home. My husband's waiting for me. Yeah, that's the need for intimacy and sexuality, correct. Right, not responding, blank stares, correct. Resisting care. Great responses. I love that everybody has some experience that they're able to share. Next slide. So before we start to look at how we're going to understand these kinds of situations, just as a quick review, the 4 truths about dementia is that there's at least two parts of the brain that are dying. There's the chemical changes that are going on with the brain, and there's also the functional changes. Brain cells are dying, tissues shrinking. And number two, it's chronic, it's progressive and will get worse. And lastly, it is terminal and it leads to death. So next slide. So the question a lot of us come across with our families, and even for myself, is I started to ask, why do they do that? You know? And in thinking about that, I said, I looked at what Tipa's model was with the gems, and that's for another presentation, but she really helps people, as she asks us as providers and families to look at what we call the 6 pieces of the puzzle. Next slide. So as you can see in the little green boxes, the 6 pieces of the puzzle, I'm going to mention the first 3 pieces. These are intrinsic situations that it's something that you don't have control over. So like the brain changes that are going on for the person living with dementia, that's not something that they can have control over, right? And I think it's important for families to get the education and the information to understand what type of dementia. Everybody just makes the assumption that everything is Alzheimer's, and it isn't. There's actually more than 100 subtypes of dementia that most of us know as Alzheimer's, but there's also Lewy bodies. There's vascular dementias. When I was working at the VA, it was interesting because we were seeing a lot of traumatic brain injury and PTSD, and they are doing research to see if there is a connection between these soldiers that have been impacted by traumatic brain injury, to see if they're gonna, they're more inclined to get early onset dementia. And to understand too what that level of cognitive impairment. The other thing that we don't have control of is the person's personality. It's going to be important to know what kind of work did this person do, but when I think of personality, what was that person's, were they more introverted or extroverted? What were their relationships with family? And more importantly, let's try to remember to think of the person first, and then the brain changes second. The third area is fitness and health. And so unfortunately, some people with dementia also have other comorbidities. And so we have to look at the health challenges, what other underlying health problems they have, and what their prior lifestyle was. The other 3 pieces of the puzzle that it's extrinsic and we can have some control over is 1, the environment. So we need to start looking at what's going on in the setting that the person's at. Be more cognizant of certain sounds, smells, even what you're seeing, but even temperature can also impact a person and their mood. Lastly, time. Look at how the person's day is structured. Most people, even people without dementia, you don't want to just spend your whole day, I don't think, sleeping in bed or watching TV. Although I know when I retire, I keep thinking I might just watch a lot of these old movies. And the last thing that we can have control over is the stakeholders. And I refer to stakeholders as the healthcare providers, the care partners. We need to be able to give more support and encouragement and train our care partners on ways that they can be more creative and positive in their words and their actions and the responses to the person that you're caring for. And it's easy for me to say that because I'm not 24/7 with my parents, but I cannot begin to fathom how difficult that can be if you're with the person 24/7. You're also trying to do telework from home and you're babysitting grandchildren after school. It's hard. It's really hard. Next slide. So just again, besides knowing what the 6 pieces of the puzzle are, we have to remind ourselves that for people that are not living with dementia, there is this hierarchy that Abraham Maslow came up. He's a psychologist. And basically, he starts at the bottom that individual human beings, they need to have their physical needs met first so that they're motivated and then can move to looking at safety needs, the importance of belonging, being loved, and eventually reaching self-actualization. But for the person that's living with cognitive impairment or dementia, they are not always, they're losing sometimes ability to communicate with in words. If they're hungry or if they're needing to go to the bathroom or if they're in pain. And so just keep that too in the back of your mind. So I wanted to talk about 5 basic unmet, there's actually unmet social needs and physical needs, because if we're aware of what those unmet needs are for a lot of people that live with dementia, they can't communicate that just to as part of your detective work. Next slide. So the 5 unmet emotional needs for people living with dementia. It's anger, sadness, feeling lonely, scared, and boredom, right? For us, again, without, for us healthy people with working brains, healthy brains, we're able to express that anger in hopefully healthy ways. But a person that has a cognitive impairment may not be able to do that. So if they're throwing an object, or swearing or cussing, there's something else. We need to figure out, why are they upset or angry? It's the same thing about being scared and lonely. I found that if staff approach a person without getting the person that they're caring for with dementia, they don't get that person's attention first, and they approach them from the back or come right up into their face, and they're not telling the person what personal care task they're going to perform. That person gets scared. They either get angry, they're going to physically try to hit because they're protecting themselves. And then the other areas of boredom and lonely. Again, like I said earlier, they don't want to just sit there feeling useless and disengaged if there's no structured activities. Next slide, about the 5 unmet physical needs. So all of us, just basic all of us as human beings, whatever we take in, right? We understand that we have to get nutrition, we have to stay hydrated, and take in liquids. And what you take in also has to be eliminated. And for a lot of people living with dementia, they don't remember or they forget they need to go. Also, their level of energy changes throughout the day. There's that interesting phenomena called sundowning, right? And that can happen, I've seen, anytime from 1 p.m. to 5 p.m. I mentioned earlier about discomfort, temperature changes, sensational changes. They are more sensitive, their skin. The skin is thinner for older people. And then again, pain. It's difficult for a lot of people to be able to tell their care partner that they are experiencing muscle pain, or some internal problem, like not just joint pain, but an internal, like if they're having a stomach ache or their chest is pounding, they're having palpitations. So those are 5 unmet physical needs of people living with dementia. We need to look at how that can impact those challenging situations. Next slide. So when I ask everyone, who do you think is affected by these challenging situations? Is it just us? On the contrary, it's also the person that lives with dementia. They are constantly, there's all these changes that are going on, not just in their brain, but it also impacts them emotionally, their social relationships, their physical activity. Some of them may be overly active. Some of them may lose the interest or ability to take those long walks that they enjoy or go surfing. And then there's always that constant change in their cognition that's changing as well. The care partner is another person that's affected by these challenging situations. They're grieving the changes in the person that they're living with. They're taking on new roles or new responsibilities. I know when I've worked with spouses, whether there's husbands or wives, they've said to me, it's just they feel like they've lost they're losing their soulmate, and that's a shell of the person that they miss so much. And then of course, care partners, they're human. They're going to start feeling frustrated and reactive. And the hardest thing for care partners is to be able to ask for help. And I think from what many caregivers have told me, some of the reasons they don't ask for help is they feel that they are failing their loved one in some way if they have to have someone come into the home, if that's private help, or to ask their siblings. And my approach has always been to say, why not give your brothers and sisters the opportunity to enjoy that time, that meaningful time with your mother or your father? And they'll also get to learn and appreciate the changes that are occurring. So we as a community just need to recognize that the person living with dementia, again, they're doing the best they can with what abilities they have left. Next slide. Oh, next slide. Is there a next slide? Okay. I will find my own slide. Okay. Oh, we're going to show you a little video about a challenging situation and when you look at it, see what you can spot and figure out as a detective. Okay, John, the video.
Challenging behaviors, that's how we see it. They're misbehaving, they have problem behaviors. We've got to do something about this. Now I'm gonna call a timeout right now because the biggest problem we have right here is you've already identified the source of the behavior. You're pretty sure it's them and what they're doing. Timeout. You need to take a step back and realize this is much more complicated than you think. And instead of being such a strong judge and jumping to conclusions, what I want you to do is back off and reframe this. I want you to realize that they're doing the very best they can to try to communicate with you, to meet a need, to express that they aren't liking what you're doing. And unfortunately, you simply see it as not getting your way. What you don't realize is that you started this very frequently in your effort to be helpful. Let me just say to you, you weren't as helpful as you thought you were. I didn't really enjoy the help you gave me. I didn't get it. So you have a choice right now. Are you going to continue to push your agenda to try to get where you want? Or can you take that step back and go, okay, well, this isn't working. Let me rethink. So what you want to do when you experience a behavior you're not liking, you need to, whoa, take that step back. Take a deep breath, let it go, and realize now it's time to kick in the front of your brain and to become a really good detective. Try to figure out what might be driving what you're seeing, what you're hearing, what you're feeling, and what they're feeling. What maybe you're smelling and they're not picking up on, what they're tasting versus what you would be tasting. Because what you want to do is realize that you need to see it from their side. And once you see it from their side, you try to be in their shoes, figure this out. Suddenly, when you see things, hear things, experience things differently, and you make that choice, that decision to do that, the uh-oh becomes an aha, because you can start to realize it's the setting, it's the care, it's the gem. It's who they were before this all started. There's lots of pieces to the puzzle. Your job, if you want to do this well and do this over the course of this condition, is to stop the judgment, time yourself out, and reframe this behavior. Go from a challenging and frustrating, I just don't understand why she's doing this, to pausing for yourself, getting some help, maybe getting somebody else to take a look with you, because maybe you just can't see it because of who you are and how it works. But what you're going to do is take that step back, look more broadly, and at that point, make a decision. What are they trying to do? Are they communicating unmet physical need? There's basically 5 of them you want to learn about. Or an unmet emotional need. Or are you seeing the emotional need, but you're missing the physical need? Or was it something that is happening in the environment or happened earlier today? As I said, complicated. So you need some training. You need to know what's going on and what's not going on so you can quit sitting in judgment and start using this. That's the best tool. That and your ability to bring people together to help you. So with challenging behaviors, it's not about them, it's about us and what we choose to do about this effort to communicate an unmet need and helping us figure out what is the need and how can we better meet it for success for both of us. Making a positive difference because we choose positive approach to the care. Now remember this lady? What do you think she's doing? You see her beating on the chairs, making noise, annoying people, and you know she needs to go to the bathroom. It's been a long time. You've tried to make her stop, but she won't. What if I told you she used to clean houses for a living? I'm going to try substitution and a positive approach rather than trying to make her quit.
Miss Leona. Well, hey there.
Get your hand.
Get my hand out the way. You're trying to get them clean. Here, try this.
She's a busy woman.
There you go.
I'm going to try a substitution here.
I'll trade you.
Not yet. Show her.
Rub it with that. Can you rub it?
Yeah.
Here, rub
We're
it.
getting there.
Trade me. Trade me.
Wait.
Trade me. Here you go. Take this.
All right, get it.
You got it. Now trade out. There you go.
Ta-da.
Now rub it.
Now I show her, and there she goes.
There we go.
People are
Good.
less annoyed, not so much noise. And she's cleaning. Now I want to reinforce it. That's good. That's good.
2 more to go.
But I still haven't met
You're doing a fantastic job.
her unmet need. One more substitution.
Nicely done, Leona.
She needs to get finished with this
Boy, you are good.
so we can move on.
You get this one?
Watch me, I'm sneaky.
That's it. Good. Good.
I visually eliminate the task.
Whoa. Woo! That is beautiful. You did a fantastic job. Man, you're a good cleaner.
Here.
Thank you. All right, well, come with me and we'll sit down and take a break.
Oh, good.
I know you're ready for
I'm
one, aren't you?
tired.
Now, before she goes to sit down, though, we have a place to go.
Oh, girl, you worked hard.
Oh, God.
You are one of the hardest working women I've ever met.
Yeah.
Well, Lord knows. Let's go to the ladies before we sit down, though.
Okay.
Okay.
We changed the challenge to success.
So I would love to hear people's comments or feedback about that. That was Tipa Snow, by the way, in the video. If you don't, I want to summarize by saying, you know, Albert Einstein, he defined insanity as to do the same thing over and over, expecting different results. You know, as Tipa has shared, reframing how we approach challenging behaviors in a positive manner is key. We need to always try to start with our own self-reflection and assess what is going on with you as a care partner before you start an interaction. And remember, if you're not in a good place at the time that you're going to have to start that interaction, it's best to give yourself permission to take a time out, especially when you're starting to be feel upset or overwhelmed or sad. And lastly, dementia is a change that's occurring in the brain. The person living with dementia can't control these changes, and they just may not remember how to verbalize their emotional and physical needs. So how we choose to communicate influences the outcome with dementia care. And pretty much this is self-explanatory. I'm not really going to go through all of these little items. I'm more interested in getting feedback and comments. The last slide is the positive approach to care philosophy that encourages care partners to respond to a person's change in thinking and abilities in a way that is not hurtful or offensive. Let's recognize that the person living with dementia is doing the best they can. And if something just isn't working right for us, it's our responsibility to change our approach and how we interact towards that person with dementia. Okay, so next month, I wanted to actually look at some positive physical approaches to care. And I'll have to try to do this at best virtually, but any comments, questions, cases? Dr. Lucas, your thoughts?
Yeah, I really appreciate all, this presentation, and especially, seeing that example of Tipa Snow kind of doing a positive approach example in real time. I think those are really valuable to see those examples. I have a case, if I could just bring it up real quick, and love to hear your thoughts and anyone else's. So I'm working with a woman in her 60s whose mother has a type of dementia that hasn't been fully assessed yet because she's still largely independent, but she has developed really intense paranoia. And I don't like to use that word. It sounds kind of judgmental. I don't mean it that way, but she's convinced that people are stealing things from her apartment, believe that they come in while she's gone, even though, of course, there's locks, etc., that are obviously not tampered with. And so daughter is very, very struggling, and mom is losing a lot of stuff and continues to call the police regularly, believing that she's being robbed. And just trying to help the daughter to work with the mom, and not having a lot of success yet. So that I'll just, I guess, leave it there for the moment. Any thoughts on that?
Yes, I mean, that's a real common thing. I mean, I wish we had a geropsychiatrist. Maybe one of the geriatricians could chime in, in those kinds of cases, because I have had people that get so anxious, right? The person, well, actually both people start feeding off that anxiety, right? Because the daughter's like, when is this going to stop? What can I do? I'm just at my wit's end. And here her dear mother is, it's very real for her, isn't it? She truly does believe that people are taking things, and it may be, most often it's misplaced, right? Or and they don't remember where they put things, or
right.
So I don't know. I know if there's more of a challenge where the person that's acting on those behaviors, the thoughts, if they start acting upon their intrusive thoughts, I think at that point I have said, it's important to consult the geropsychiatrist, which there's not, I don't know, Dr. Wynn, how many are left in the community? How many are available, I should say. It's hard to get a geropsychiatrist for medication.
No, it's pretty hard. That's why we have to be very creative, I think, because we really don't want to be prescribing meds anyway, if at all possible. I know it's not always possible, but if possible, remove the trigger. Something triggered them to think about this. I'm not sure what it is or if it's even possible to remove the trigger sometimes. But one of the things that comes to mind is maybe, keep them busy so they don't have the room in their brain to wander to that thing again. You know,
Is there a
like,
certain time of the
Yeah.
day that it's happening to, like to look what time of the day that there's no specific time?
Good question.
Because
Yeah,
I would
she's
see that with, in the daycare center, we saw it specifically with two people when it was right after lunch. It was like about an hour or so. And what we realized is they need to go bathroom after they ate.
Mm.
And I said, hey, did anybody take Mrs. Sakamoto to the bathroom before lunch? No, I thought so-and-so did it. I said, that was one thing that we looked at. And then again, for the people that started to escalate after one, like it was time to go home. I've been here too long, Sarah. You can't keep me a prisoner. And it's validate. You do this, Dr. Moore. You do a lot of validation therapy, probably with the person and the family. So that I go, you're right. Wow, you feel like a prisoner. Well, what about it? And then we tried distraction. What about we're gonna play bingo and we have some great new prizes. Everybody loves prizes. They love, right? Everybody in the audience knows they like freebies. And if you can get that and some ice cream or cookies out of it, most of the time it works. But yeah, you have to try to, and you know what? It's like Dr. Wen said, one day it might be a certain trigger, and then and tomorrow, maybe not.
Yeah, and I think the hardest part is, her particular expression of dementia right now is very unique in my experience in that it's extremely intense with this belief of being robbed daily almost, but most other parts of her cognitive functioning are intact. So she's by herself, living alone, independently, and so, and not having great relationships with her family anymore. She's definitely on her own a lot. And like you said, Dr. Wen, it's being not occupied or engaged in anything, the mind can much more easily fall into those fears. And so, yeah. So working with the daughter, mostly just trying to help her, like, this is not your mom trying to be, make you go crazy. It's her brain disease. And it's hard for you. It's hard for her,
Yeah, and living alone is a challenge in and of itself, because you're much more isolated, no? And so
Yeah.
you lose track of time, the day, or whatever is going on. And so you may think that someone did take something, but you gave it, or whatever. And so some creative things. Try to see if you can replace. I don't know if the daughter. I don't want to feed into, that paranoia, but I don't know. Just try different things, like what you're doing. And I think it's critical. You're there for the daughter. She's the one that's
yeah. And I worked with the mom initially to try to help with her anxiety, and one thing we tried to do is, why don't we offer them something? The folks who are coming in and taking stuff, why don't you go and set some cookies out for them and welcome them and say, help yourself, and see if you can turn her perspective on this fear. But yeah, no, nothing. She's just calling the cops a couple of times a week, and there's, rationalizing doesn't help either. So that's the other thing, trying to rationalize. The daughter does that, frequently, and it's never worked, and it just makes everybody frustrated. So yeah, so it's kind of like a damage control situation. It's because she's, she's very independent, so there's not a lot of affecting her environment or her, so anyway, just a challenging case that I'm kind of in the midst of right now.
Yeah.
I just wanted to point out that Sarah offered an alternative explanation. So they're stuck on this one explanation for why the keys are missing. And you can say, well,
Yeah.
maybe, something else.
You know
Yeah.
what?
Yeah.
Johnny, your son borrowed the keys. That's what happened.
Yeah.
I'm
And
gonna
then
talk to him and I'll make sure he returned it to you, And you should go, oh, thank you for doing that. I didn't know I didn't give him permission. So I'm gonna have a good talking with my brother so he doesn't do that again.
Right.
Yeah,
Yeah.
that's great. I love it. Yeah.
Yep. It's try everything and
And it
see
was
if anything
interesting
works. Right.
because I know some of my siblings, well, some people feel like these white lies that I'm telling to my parents is hurting them. But my dad is so happy when he knows, oh, Sarah, can we go to England, next year? I said, why not? What part? And then he'll just distract and say, so tell me, what do you miss most about England? And where in England do you want? Because my parents met in England and they were married. And we have a nice conversation then about his memories of London. And he forgets about wanting to travel. Whereas other family members will say, you know what? He can't go. He can't, it's too much work. He's 93, and he has this going on and that. I said, so what? Just be present with the person. And what harm does it do meeting his need emotionally to feel like he still can travel?
That's a good example of, you're right, speaking to the emotional truth of what the person's reality is expressing right now versus the actual truth in our shared version of reality that he's just missing England. And so, engaging him in that discussion of where would he want to go and what does he love most about being there and what does he want to see, that just engage him in his reality and speak to that emotional truth. So
and I've
really
learned a lot more about my father as a person and his past because I've been able to let him talk about that. So
yeah,
for sure.
it's great.
Anyone else comments? You're having the chat and questions, right?
Yeah.
Well, I'll just say that's why they call it therapeutic lying, because it helps.
Hey, Mary.
Yeah. And I remember a friend of mine who had her mother-in-law had really bad dementia, and she always talked about have fun with it. Just have fun with it. Don't get all bunged up about it. Find a way to make it fun for yourself and for your loved one. That's my only comment. Yeah. And the other thing is Tipa Snow. I think she's like a magical worker. I just love her videos. I could watch them for hours. She's just amazing how she can just figure out is like a sixth sense what that person is feeling and just the right thing to say and do that will comfort that person and get the results she wants. Yeah, so I'm a big fan of Tipa Snow.
Mary, anybody can learn that. It's taken 4 or 5 years. And I think one of it was, for me, it was more being introspective and having to really look at what my agenda and my issues were. And there were a lot of issues that I have with my parents. And deciding, you know what, Sarah, this changed at 92, 93. So who's going to have to change?
We are, yes.
And I don't get angry and frustrated with them anymore. And I love them dearly. I mean, I really can say that. Before I used to say, the other thing was I used to say was sorry, but I really didn't mean it, you guys. I'm really sorry. No, but no, I do feel sorry. I mean, I am sorry if I say something that's hurtful or offensive because I'm human and I make mistakes and I get impatient,
Yeah. I'd like to invite Diane to speak a little bit because I know Catholic Charities has a program. Do you want to share, Diane?
Hi there. So, yeah, we do have a program called Reach Community where we have certified coaches that will help do some one-on-one coaching for caregivers who are caregiving for someone with dementia. So part of what they look at is not only how to cope with caregiving, but also how to work with some of the behavioral issues. So that is something that they can contact Catholic Charities. Our intake line is 527-4777. And we have also trained some coaches over at Queens, because I think Debbie's on the line, and Maria over at Project Donna. So we have some other coaches in the community who can also offer that intervention.
Thank you. Does Maria Morales want to say anything?
Yay, Maria.
Hi. Yeah, so I'm just as Diane said, I'm one of the certified coaches to provide the REACH community program. And we also have our regular caregiver support group meetings to our members, where we have information about different resources, community resources that caregivers can connect to, or even we invite professionals that can talk about different caregiving strategies that they can use in their situations. Thank you, Sarah, for all the great information. I've gone through the positive approach to care trainings with Dorothy Colby, and I have to say that along with what I learned with REACH, you know, I share what I learned from that when I do the trainings as well with caregivers. Thank you.
Any other ideas or stories to share? Challenges?
I just gonna make a couple of comments. I remember, and for those who have been in geriatrics or just in practice, and Dr. Morgan knows this too, I purposely changed the title because 20 years ago, we used to look at the situation as though the individual that's living with dementia is the problem, right? So we refer to it as difficult behaviors, managing difficult behaviors. And it's as though we don't own it anymore. We've put that onus on the person that doesn't have the ability. The other thing we used to call disruptive behavior. I used to say, what the heck is disruptive? I'm pretty disruptive. So the other thing is, when you look at the challenge, when you look at the situation, stop thinking about the behavior. Look at the situation, and ask yourself, really, what do you think is going on? You know, because they're not really. I think Dr. Lucas said it again. They're not doing this on purpose. And if you're not specific about a behavior, you can't say it's disruptive, because all of us in this room have had difficult behaviors at one time or the other. It's been perceived as that, a disagreement, an argument, you know, but nobody labels you a problem yet. Thank you.
So I have a question, because I live with this every day too. What do you do with kids, the grandchildren that interact with grandparents and having, them teaching them how to handle grandpa, when I find that particularly challenging. You know, it's for me, it's like, you know, here I am in geriatrics and I want, you know, the grandchildren to honor and respect grandpa, but when things get kind of hairy and they can't, you know, it cuts to my heart, and I don't know what to, you know, how to spin it sometimes. And I don't know if there's actually any like Project Donna or Catholic Charities, is there any programs for helping kids with this?
Yeah, there's definitely a need for intergenerational type of thing, more intergenerational education or just the exposure. I don't know if any of you saw Kumu Kahua. They have on YouTube a nice little play they did, and it's still probably on YouTube. It was about a month ago, and it was a story about a grandmother and her living with dementia and her relationship with an adult grandson. It's called Who Are You Again? So if you can go on YouTube, they did a superb job. You'll laugh and cry at the same time. And I'm hoping, Aida, I can get access to that video as a teaching tool. It was really a local spin.
That would be fantastic. I think that in order to keep our kupuna in the community, you know, we really have to teach others how to connect with them and how to, instead of, oh, I avoid them as much as possible and then I don't bring my friends over because.
Yeah, yeah.
And that isolates them further.
I really commend you for just your courage to continue to, you know, engage your own your own children with their grandparents, because I think that is, you know what, it's a circle of life. I didn't need to see that. And, you know, my children, I don't know if it's good or bad, but my children experienced a lot of that with us being caregivers. And as adults that are 37 now, the older one says he wants to come home to take care of us. I'm not really sure I want him to take care of me. He's in law enforcement, bless his heart. But see, it was interesting. And I just asked him, I said, why do you want to take care of us? And his comment was, because you took care of grandma and grandpa.
Mm-hmm.
So it's like there's no coach. And we, of course, I said, you know, it was very stressful. It was taxing on our marriage. I don't want you to feel you're obligated to do this. It's nice, but you know, we have long-term care insurance.
Oh, this is such a great conversation, but it's 1 o'clock.
Okay.
So we're gonna have to go, but you know, come back next month. Sarah is gonna speak again, and we'll get
Do
a
some
chance.
demonstration stuff. Maybe I'll pull Aida. Maybe I'll pull you in, Aida.
Thank you.
All right,
Okay.
thank you, everyone.
All right, make sure you fill out the evaluations to get your CME. I think it's in the chat box. Make sure you click on that before you exit. Okay, you got a moment? You clicked on it? Okay. All right, thanks for joining us.